Welcome to Dysphagia in the Schools Part 2, Dysphagia Screening by the Speech-Language Pathologist. This is the second segment in a 4-part series in which we are discussing dysphagia management in the schools. After participating in this webinar, please proceed to presentations 3 and 4. This webinar is presented by the Virginia Department of Education. My name is Julian White. This presentation will focus on the swallow screen in a school setting, ASHA guidelines for dysphagia screening, and when to refer for further testing and evaluation. Here is a brief review of important vocabulary for this module. We will go over the difference between modified barium swallow studies and fiber optic endoscopic evaluation of swallowing in more detail later in this series. As we discussed in the first module of this series, the Individuals with Disabilities Education Act and ASHA Practice Portal on Pediatric Dysphagia provide guidelines relative to children's safety during feeding and swallowing while in school, as well as how the student's health influences academic progress and the child's ability to participate fully in school activities. Please also refer to the VDOE document on speech-language pathology services in the schools, Guidelines for Best Practice, updated in 2018. Dysphagia management information can be found starting on page 64. Please see the attached document entitled Pediatric Feeding and Swallowing Resources. For a comprehensive look at dysphagia management in the schools, Emily Homer's book, Management of Swallowing and Feeding Disorders in the Schools, is another well-noted source. This is a powerful quote from Dr. Joan Arvidson. All children need adequate nutrition provided in a non-stressful way so they can maximize their learning potential in an educational setting. Collaboration between school and medically based personnel is important to maximize the health and well-being for all children who need optimal nutrition and overall health for effective learning. As a school-based SLP, you will be a key player for a school swallowing team as it approaches the management of dysphagia within the educational setting. You may be working closely with the following individuals. An article by Engel, Bailey, Nicholson, and Stoner in 2009 found that when parents or guardians are involved throughout the learning or therapy process, the student progresses more quickly, and there is often carryover to the home setting. So remember that parents are also an integral part of the feeding team. The evaluation process begins with a referral, which can be initiated by staff within the school, parents and guardians, or outside health professionals like the child's pediatrician. Once a referral has been made, the school system needs to contact the parents to obtain consent for an evaluation, which is an opportune time to interview the family members to gather information about case history. This is part of the screening process to determine if a clinical evaluation is warranted. VDOE lists the following warning signs for dysphagia and aspiration that can be used as red flags for referral for a full feeding and swallowing evaluation. Remember that some warning signs are not as overt or easily identifiable. Many subtle warning signs can include reduced alertness during classroom activities, overall health issues, or even limited social interaction during mealtimes. The goals of a swallow evaluation are to determine if there is a feeding or swallowing impairment, or a high risk for one, what the cause of that issue might be, for example, neurological or sensory, and to determine the need for further testing or evaluation by medical professionals. This process should include observations of feeding and swallowing, if appropriate and safe. Of note, a clinical swallow evaluation should provide information about the child's oral preparatory and oral phases, as the face and oral cavity are accessible for examination. However, screening for the pharyngeal phase is less transparent since the pharyngeal phase is not directly visible. Now we will go over the key components of the swallow evaluation. Key components of a swallow evaluation include a thorough history, an oral motor and general physical exam, an observation of feeding, and an assessment of indicators for referral or instrumental testing. The first part of screening and evaluation is a careful and detailed case history, typically gathered during an interview with the parent or guardian. Case history includes multiple pieces of information, from family and psychosocial history to medical and developmental history. A well-executed case history will provide significant insight and guidance to the student's swallowing and feeding issues and the appropriate interventions. It is important to gather information about the child's family history, as appropriate, including significant medical or psychosocial problems that run in the family. It is also helpful to know if siblings or other family members had similar issues, as this may provide clues to etiology and treatment options. For example, if a sibling had food allergies that caused similar feeding behaviors, then it would be important to look into that for this child as well. Although we are discussing school-aged children today, it is still important to review the child's prenatal and perinatal history, particularly if the child has a history of prematurity and/or prolonged hospital stays in infancy. This information will help you understand the etiology and determine prognosis. For example, if the child has experienced persistent feeding difficulties since infancy, this fact might impact your treatment approach and long-term goals. If you recall in the last lecture, we discussed the relationship between motor development and feeding development. Therefore, if a child was delayed in a motor act, such as sitting, that certainly could impact the trajectory of feeding development. Of course, medical history is paramount to a comprehensive feeding history, particularly when determining the etiology of the feeding or swallowing impairment. For example, asking the family if the child has frequently been ill with respiratory illnesses may raise a red flag for chronic aspiration. In addition, if the child has a history of gastrointestinal surgeries, that could raise a red flag for reflux or esophageal dysphagia. These issues could be contributing to the child's food refusal. Even a list of medications can provide critical information about the child's current and past feeding, as well as suggest red flags for possible medication side effects that could be contributing to fatigue or nausea. Growth history is also important. Past problems with growth or failure to thrive can clue you into chronic issues that may or may not have been addressed by the time the child comes to school. I also find it helpful here to ask if the child requires any supplementation to maintain growth. For example, the child may be at an adequate weight now, but when you dig deeper, it turns out they have to drink 3 Pediasures a day to maintain that growth. That might be a sign that there are some underlying issues regarding growth and food intake that haven't been fully resolved. Similarly, taking a detailed nutrition history can be helpful. For example, if you find that the child didn't transition to solid foods until 2 years old or had tube feedings as an infant, these might be warning signs for some developmental and/or safety concerns that may still be impacting feeding performance. Psychosocial history is essential to gather, not only to better understand if there are some behavioral issues around food, but also to know what type of supports the child might have at home, particularly if you are making feeding recommendations to families. The final and most crucial component of the case history is gathering information about the child's feeding behaviors. Sometimes a child will demonstrate behaviors at home that we know are suggestive of underlying dysphagia, but their family has observed this behavior in the child's feeding over the course of their entire life. They may not recognize this behavior as strange. It's just how their child eats. One of my favorite questions to ask is what types of food a child likes or dislikes. While the parent might think that this is just the child's taste preference, you can glean important information. For example, if the child happens to refuse raw veggies, sandwiches, and steak, the parents might write that off as just a picky child. But you, of course, would question if there is either an issue with chewing or possibly esophageal dysphagia. I also always ask the parent to write down a typical feeding schedule. Notice if there are any patterns that emerge, like always snacking or grazing throughout the day. Or maybe the child refuses to eat in the morning, perhaps suggesting the child has reflux at night. The next part of an evaluation should always be a physical exam of the child, both generally and specifically of the oral cavity. Observe the child's lips, tongue, jaw, dentition, and hard and soft palates, and assess their coordination while eating and swallowing. Are they working together and functioning properly? Note any asymmetry, drooling, or range of motion or pattern abnormalities like tongue thrusting. Asymmetry can indicate a neurological issue, and drooling may indicate sensory input problems or inadequate lip closure. You can also use activities to view these structures in action, such as cup drinking, eating from utensils, biting or chewing solids. Notice how the child manages different textures and modalities. Can they close their lips around the straw? When the child takes a bite of food, does the tongue come and protrude from the mouth? During this process, it is also important to evaluate the child holistically. Look at their behavior, posture, and muscle tone. Do they need assistive seating or positioning? Does the child sit independently? Is the child's breathing labored? Does the child sound congested? And is the child able to use utensils? Now that you have completed the case history and general physical exam, the third part of the screening process involves observing the child during lunch or snack time at school in as typical an environment as possible. Make sure to take note of how much assistance the child needs, the types of foods they're actually consuming, and how long it takes to finish the meal. Is the child the last one at the table? Is most of the food still on the plate at the end of the meal? Also, notice the social interactions and behaviors. Does this seem like a positive experience, or is the child crying, moving the hands to cover the face, or turning away in avoidance? During your feeding observation, you should also be monitoring for overt signs of aspiration, like throat clearing, coughing, or choking. However, please keep in mind that many children have silent aspiration, meaning that they show no outward signs of aspiration. The absence of a cough does not confirm a safe swallow. Don't forget to notice other behaviors such as gagging, spitting food out, or even pocketing food in the cheek pockets. During the screening, be alert to any overt signs of aspiration. If you do notice any warning signs and/or believe that the child may be at risk for aspiration based on the case history, it is likely that you will refer the child to a physician for a follow-up. The physician may then order a modified barium swallow study, or in some cases, a FEES, or fiber optic endoscopic evaluation of swallowing. Although you have likely seen instrumental images previously, a quick review is provided. On this slide is an example of what you would see during a modified barium swallow study, and on the next slide is a view of the larynx during a FEES, or fiber optic endoscopic evaluation of swallowing. This picture is a still shot taken during a FEES in which you can see the larynx from a bird's eye view. Obviously, these are two very different views, and each can provide you with varied yet objective information of the swallow. We will talk more about these two tests in the next module. This resource is from the ASHA practice portal on pediatric dysphagia that outlines indications for instrumental testing. Obviously, if you suspect dysphagia and are concerned for a child's safety, that is a valid reason to refer for instrumental testing. This is true particularly if the signs you're seeing are inconsistent or unclear. For example, if the child coughs sometimes, but not always. If a child has a history of dysphagia that has been managed, but they have recently experienced a change in status, repeat instrumental evaluation would be warranted. For example, if they had a medication change, surgery, or significant illness, in particular a hospitalization for pneumonia, instrumental testing would be advised. Here are the references for Part 2 of this 4-part series. For additional resources, please see the attached document entitled Pediatric Feeding and Swallowing Resources. This completes our review for Part 2 of Dysphagia in the Schools, Screening and Evaluation by the Speech-Language Pathologists. To receive a certificate of completion for this module, you must pass the VDOE knowledge check with a score of 80% or higher. Return to the VDOE SLP Professional Development page to take the knowledge check. For continued learning, Dysphagia Modules 3 and 4 are also available on the VDOE SLP website. Thank you for participating in this webinar presented by the Virginia Department of Education.